we'll make a start. So, welcome everyone to part 7 of our 8-part webinar series, How to Survive a First Surgical on Call. Today we'll be talking about the complications of some of the most common operations you'll come across on your surgical jobs, the specific management strategies and escalation pathways. It's going to be run by Thushanth, who's a colleague of mine and a surgical SHO, as an ENT applicant, having done experience in Gen Surg, Ortho and ENT. So we'll be taking questions via the Q&A function, and we'll either answer them as we go along or at the end, depending on the volume. And we'll have a QR code on the very last slide for feedback. So if you guys wouldn't mind filling in that form, it takes a couple of seconds and you get a certificate to show that you've attended the series as well. So I'll pass over to you, Thushanth.
Perfect. So cheers, Carl, for that introduction. So my name is Thushanth. I currently work at in A&E in my F3 year, but I've done quite a lot of surgery now. So I've done Ortho, Gen Surg and ENT and provided quite a lot of cross cover. So today I'm just going to go over the most common sort of bleeps that you would get from the ward, and then really talk about your escalation plan, when to involve your seniors and what to do before you involve them. So go on to the first case. So you're on nights and you've been bleeped. Patient on the ward is complaining of abdo pain and they're spiking a temperature. So you'll get this all the time when you're covering nights. So you ask a bit more questions over the phone, obviously. So he's a 64-year-old male, 4 days post-op, low anterior resection, complaining of increasing abdo pain. So you ask for the obs over the phone, and the nurse says heart rate 130, blood pressure 90/63, rest rate of 24, SATs 95 on air, and a temperature of 38.1. So the first thing you think of when you get read out some obs like these is, this patient sounds very unwell. You're going to probably drop what you're doing and go to assess this patient immediately. They're grossly hemodynamically unstable at a heart rate of 130, and they're obviously shocked as well with a systolic of 90. So you go over to the patient, you get a brief history. So you find out that they're 4 days post-op, a low anterior resection with end-to-end anastomosis. They had this done for proximal rectal cancer. And you ask the patient, and they've been complaining of what started off with quite generalized abdo pain for the last 8 hours. But now it's just getting of increasing severity. And you're quite worried about this patient. From the end of the bed, they don't look so good. And that's one of the first things when you assess. It was one of the key things you learn in your first couple of years after graduation, just to eyeball the patient and just be able to tell who looks unwell and who's okay. So of course, you start off, as with any sort of assessment, your A to E examination. So airway's fine, breathing is tachypneic, respiring 24. SATs are okay for now. Do a quick listen of his chest. It's clear on auscultation. You move on to circulation and you see his heart rate is 130, blood pressure 90 systolic. His capillary refill is 3 seconds. So you see he's not, you see he's clearly underfilled. The first thing you're probably thinking is this patient septic with this high temperature as well? You do D as formality, GCS 15, and you move on to the most important part of this examination, which is E, you assess his abdomen. You're trying to do this A to E in the first minute, basically. Of course, by the time you get to EE, assessing his abdomen, you would have already asked a nurse to just put up a bag of fluids, just do something to bring that heart rate down and get that systolic up a little bit. So the most worrying findings now is that his abdomen on palpation is completely rigid. There's generalized tenderness. There's signs of local peritonism with diffuse guarding and rebound tenderness on palpation. These are all absolute red flags that this patient, in a post-op cancer resection patient, this patient's clearly peritonitic and also septic. So what would your differentials be? So you're going to get calls from the ward for abdo pain and fever quite a lot. But with that hemodynamic instability and with that rigid abdomen on examination, you're going to think, could this be an anastomotic leak? And because his abdomen is rigid, you're thinking this is probably some sort of fecal peritonitis. The other thing this could be, but if they weren't so unwell, you could think perhaps it's a post-op abscess or collection. But we're probably going to go with the anastomotic leak. So what would you do? This patient, as an F1 or even as an F2 SHO, this patient's clearly very unwell. You want to speak to the registrar immediately. You want to, if they're not to hand, you have to fast bleep them and let them know about this patient. With those obs, heart rate of 130 and systolic of 90, you're thinking, is this actually peri-arrest? So depending on how quickly your registrar can get to you, they could be, for example, in theatre doing an emergency case, your SHO might be in A&E resus, and you could be left alone on nights with this patient. It won't always happen, but it's a possibility. So you do always have the option of putting out a MET call for this patient. And no one's going to blame you for putting out a MET call when you think a patient's so unwell. And this, you could say this is a peri-arrest. And to be honest, as an F1 or SHO, all you're expected to do for this patient is just recognize the fact that they're seriously unwell and that you need help ASAP, basically, from far more senior people than ourselves, basically. But in the meanwhile, you've already put up a bag of fluids, a few stat boluses of any sort of crystalloid of your choice. And you're going to initiate sepsis 6, or at least try and start it. Your registrar will give you a bit more guidance. Of course, they'll be on their way. But you initiate sepsis 6, you will start the antibiotics, give the fluids. And to be honest, this patient's not hypoxic, but you can give high flow oxygen as long as they're not a retainer. And at the same time, do the cultures, do the VBG, and measure, well, see if they're catheterized to measure their urine output. But by that point, you would get senior help. And everything from there is just really, you get told exactly what to do and you just have to carry out the instructions. So this patient will be kneel by mouth. They'll get some sort of imaging for this patient to just confirm the diagnosis. So they'll get a CT abdo-pelvis for this. And at the same time, your registrar or your SHO might get you to go to theatre to make sure this patient's booked for CPOD, let the anaesthetist aware, let the theatre coordinator aware, and just get the ball rolling, really. But as I said, the most important thing for any sort of junior doctor here is just recognizing how critically unwell this patient is and not delaying prompt assessment, basically. So, does anyone have any questions for that?
We're okay so far, so we'll carry on.
All right, fair enough. So the second scenario is quite similar, at least in presentation, or at least what you get told over the phone. Again, it's a 68-year-old female, sorry. who's presenting with abdo pain and a fever. So this patient is 5 days post-op a left hemicolectomy. So from this point, it's pretty identical to the first scenario, but you ask for the obs as you do over the phone, and it's SATs of 98% on air, rest rate of 17, blood pressure is fine, heart rate is fine. They are spiking, however. So immediately, in contrast to the other patient who's grossly unstable, verging on a peri-arrest sort of call, this patient, you have a bit more time to see them. You should still see them promptly because they are spiking, they'll need cultures, etc. And you need to see what you're dealing with exactly. But you've got a little bit more time. If you're doing something very urgent, then you can prioritize that over this one and be justified in doing so. So you go over to the wards and you again do a history and examination. This time it's 5 days post-op, another colorectal resection basically. This patient, you find out, has been spiking intermittently throughout the day, and they're complaining of this periumbilical pain. It's not quite generalized all over the abdomen like the previous patient, and it was of gradual onset. So again, start off with an A to E, airways fine, rest rate and SATs are stable, heart rate is 90, they're warm, well perfused with a good systolic. The cap refill time is normal, you're not worried, GCS 15. They are febrile, however, and you can see that they've got a soft abdomen, but tenderness periumbilically. So again, in contrast to the last one, no instability here. You could just rattle through your A to E in literally 30 seconds. And you get to E, abdomen soft, so it's not something that needs immediate action. You have a bit more time to gather some more information before talking to your reg. So just elaborate on the examination findings. So the abdomen's soft, but there is tenderness on palpation of the periumbilical region. So there's no signs of peritonism. There's no rebound tenderness, percussion tenderness, or any sort of guarding here. So from an examination point of view, this patient looks okay. Just as a little aside, you think there's a bit of a fullness on palpation periumbilically, which is sort of trying to hint at a possible diagnosis for this patient. So again, I mean, it's quite a similar presentation to the previous one. And so the two differentials would be these same two, but because of how well this patient is, and because it's a local fullness that you could feel on palpation, you're more inclined to think that this is some sort of post-op abscess or collection. And this is probably one of the most common things that you'll get bleeped about when you're providing ward cover on night as the F1 or SHO. So how would you proceed? So you have a lot more time with this patient than the previous one, as I mentioned. No one would blame you if you decided to call your registrar again, just straight away, but there's certainly no need to fast bleep them. Or perhaps if your surgical registrar is at home, which is very rare, but some sites do that, you don't need to call them straight away, perhaps. You can gather a bit more information before calling them. So it's a spiking patient. You're obviously going to prescribe them some paracetamol, some fluids, just as maintenance for the insensible losses from being pyrexic. Again, you'll do all the baseline sort of investigations. So you'll do your blast, you do your VBG, look at their lactate, and of course do some cultures. And at this point, then you can call the registrar. Again, the reg won't blame you for calling them earlier on, but this is what they're gonna ask you to do. And then again, just like the last one, the registrar will give you what to do next, basically. So again, this patient will get a CT abdo-pelvis, and then they'll proceed depending on what those findings are. So just to reiterate the differences between these two bleeps, which from the outset look quite similar. It's just another abdo patient, a patient with abdo pain spiking a temperature. You'll get millions of these bleeps. So it's really important to find out quickly who's unwell and who's not. So 3 things I've just listed here. 2 of them, well, one you'll know over the phone, which is their OBS. You can never go wrong with just judging how ill a patient is from their OBS. And also, I didn't mention it here, but you can also just trust the nurses who've been on the wards for many, many years. If they say someone is very unwell, they're worried, then you should probably go, having 2 months of experience in Gen Surg. And once you get there, things that are guiding you is your sort of eyeball assessment from the end of the bed. If the patient looks just not very good, then you're just trust that hunch basically and treat it with the appropriate level of seriousness. You can go off the OBS, and then you next thing that will guide you is your examination. And to be honest, the fullness that I mentioned in the abdomen, it doesn't really matter if you don't pick that up. The only thing that really matters is this patient peritonitic or are they not? Or even more simply, is this patient's abdomen soft or is it rigid? And if you just do those things, you won't miss a seriously unwell patient. And again, in terms of escalation, which is what this lecture is sort of about, of course, you're going to escalate pretty much everything to at least your SHO, maybe your registrar, but it's about when you want to escalate to your reg. So bleep 1, you're clearly going to be out of your depth. You want more hands on deck immediately, and the registrar just needs to get there ASAP. Whereas bleep 2, you won't be faulted for calling the registrar, but you won't go wrong with just gathering a little bit more information so that you can give a reg some sort of coherent assessment of what's going on the wards, and they'll thank you for it. So the next one is not actually a Gen Surg case, it's an ortho case. Sometimes as gens, when you're covering surgical wards, you're often expected to cover the ortho wards as well. So I thought I'll just chuck this one in there as well. So your the F1 or F2 on nights, the reg is off-site, which they often are for orthopedics. And you've got a 23-year-old male complaining of leg pain. Nurse tells you over the phone he's got a closed tibia fracture awaiting surgery. And then you ask for the odds, as you do. So heart rate 105, blood pressure 130, rest rate 18, SATs 98% on air, afebrile. Just from those odds, you're not, too worried. They're in pain, so their heart rate's going to be up. But you want to go and assess them, and they're young patients, so any sort of decompensation will happen late. So heart rate's the first one to go up. So you're going to go and see them promptly anyway. The other big thing is the fact it's a closed tibia fracture. So I'll come into that later. So you go and see this 23-year-old guy. He's come off his motorbike, and early that day, he sustained a closed tibia fracture, as I said, and he's got a back slab on, put in by A&E. So he's admitted by the day on call, and all you really know is that this patient's going to have open reduction internal fixation next morning on the trauma list. So it's just about getting through the night. But you hear he's complaining of increasing pain over the last few hours. So you have a look at the drug chart, and you see he's got Oromorph, maybe 2 to 4 hourly, paracetamol regular, ibuprofen regular, maybe codeine regular as well. So he's pretty much maxed out on analgesia. The only thing you can go from here is maybe IV morphine. And like I say, he's awaiting surgery in the morning. And none of these, the analgesia has all been given. He's on maximum possible titration of these. You do a quick A2E. Again, the A2E is just a rapid assessment. So airway, own, breathing, rest rate's a bit high, maybe because he's in pain again. Chest is clear, stats are fine. Heart rate 105, but you think he's warm, well perfused. You don't think he's shocked like that first patient was in this lecture. And his blood pressure is absolutely fine. Bit hypertensive maybe because he's in pain. GCS fine, afebrile. But you can't help think this patient is literally shrieking in pain. And you're going to have a lot of patients on the ward who are sort of time wasters, I guess. They're in pain. But this one, you really, you think this is organic. You really think he is in a lot of pain. He's got the back slab on his lower leg. You do an examination. It's warm, well perfused, pulses are intact, motor sensation intact distally. So all good sign, all things that you would do for any sort of joint. You're always going to assess the neurovascular status peripherally by testing the motor and sensation, and also ideally the pulses, but if you can't reach the pulses, you at least do a capillary refill. So in that regard, it's looking fine. So he's just complaining lots of pain. You do your look, feel, move, and one thing that sort of it's apparent is that the pain is especially bad on passive flexion of the joint. So it's dorsiflexion to this ankle joint. So what do we think this could be? So this is a closed tibia fracture, like I said, which is the most common fracture to get compartment syndrome in. And compartment syndrome is, there's only two real orthopedic emergencies, and that is compartment syndrome and neck fasc, or necrotizing fasciitis. So it's important to be able to spot this one on the ward. So closed tibia fracture is just textbook for developing compartment syndrome. And then the other thing is pain worsening on passive flexion, as again, it's the earliest sign of compartment syndrome, and it's quite a good indicator. So what do you do? This is sort of on the same range as the first scenario in terms of how serious this condition is. So you would want to, after doing your quick examination, speak to the registrar immediately. So if your ortho reg is at home, say this is like 3 a.m. in the middle of the night, you just call them. You just have no fear of waking them up, and they want to be woken up for something like this. And even if it's not compartment syndrome, they're not going to blame you. They would want to come and assess this for themselves. And from there, as with the same as the other cases, the most important thing is just recognizing how serious this matter is. And once you've recognized and escalated to the reg or whoever it is, you just get told exactly what to do. So after this point, for compartment syndrome, reg will tell you, just make them kneel by mouth. You'll probably cut open the cast, just open it up like a book, and then elevate their leg. Again, these are all very temporizing measures. This patient needs to go to theatre ASAP, but Reg needs to get in his car, get into the hospital. So these are the things that you do in the meanwhile. And then the things that are really useful to your seniors are, if you book this patient onto CPOD, alert the theatre staff and alert the on-call anaesthetist that you've got a CPOD 1 emergency, basically, because this is not life-threatening, but it's limb-threatening. So you get your consent. You obviously can't consent as an F1 or SHO, so you'll just get the consent form ready, let the patient know what's going on, and you might try and treat or give a few more painkillers. Of course, your options are a bit limited, so Reg will tell you what to do, or you can even ask the anaesthetist to manage pain. This patient could warrant a little bit of IV morphine. So just a little bit about compartment syndrome. So this patient's, the only treatment for compartment syndrome is prompt surgery. So this patient will get a 4-compartment fasciotomy. And without it, you only have hours to do this, or you will lose a limb. So just to go back, you might have heard of the 6 Ps for any sort of acute limb or for compartment syndrome as well. And that's classically no pulses, no paralysis, paresthesia, and so on. But to be honest, the only one that really matters is pain, which is why I've really reiterated it here. Because by the time you have a pulseless, paralyzed leg, it's too late, and the only option is amputation at that point. So it's just really important to remember it's a very quite specific subset of patients who will get this. So it's a closed tibia fracture, which is by far the most common one, and it is pain which is far out of proportion to the examination findings that you've got. Much like it's a bit akin to mesenteric ischemia. There'll be not much abdominal findings, but the patient's really screaming in pain. So again, it's just about realizing how serious this case is, and then just going to assess them immediately, and then just waking up your registrar or escalating immediately. And then finally, the final scenario is, again, just classic. It's a 44-year-old female, day 2 post-op lap chole, basically. Again, you ask for some obs, heart rate 110, blood pressure 103, it's not bad, it's holding, rest rate of 19, SATs of 98% on air, temperature 38.5. So I guess this goes somewhere, if we're sticking with Gen Surg, somewhere in between the first and second scenario in terms of how unwell they seem over the phone. Systolic of 103 is not too worrying, but they're post-op, they're spiking, they're tachy. You want to go pretty promptly to go and assess this patient to see what's going on. So this patient's obviously just, their analgesic requirements is just going up and up, despite parenteral analgesia. You got the history, the day 2 post-lap chole. And again, just the same formula, do a quick A2E. Airway's fine, chest is clear, bit tachypneic. They are tachycardic and hypotensive, not to the sort of peri-arrest levels of the first one, but I mean, this could be sepsis. But this could also be, you'll learn once you're on the wards that this could actually just be a normal working blood pressure for a patient, especially in the elderly, and especially for females. You do your examination, obviously they're spiking, and they've got rebound tenderness and guarding. And you look at the drain, see it's draining, or how much bile it's draining. So you do your review here, you look at the observations, you see if there are any previous spikes, what the trend is, look at their previous heart rate and blood pressure. Like I said, this could be a working blood pressure for this young lady, basically. Well, this lady. You'd look at the fluid balance, their output, are they just depleted a bit intravascularly? Have a look at their input output, and then just look at the drug chart. You do a lot of times get called saying, oh, this patient's in pain, and you realize they haven't actually received any analgesia in the last 6 hours. So have a look at the drug chart, have a look at whether they've had all the antibiotics and so on. If you're being very thorough, you can go through all the notes, look at the indication for the operation, look at the comorbidities, was there any problems intraoperatively? What was the post-op plan? The operating surgeon quite a lot of times tells you sort of what to expect in the next few days and what to do. And sort of more importantly, is this a gradual or is this a sudden deterioration? And again, just look at any blood tests and any sort of imaging. So unlike the first one, again, you have a bit more time to gather yourself, look at all the information that you have to hand before you make a decision. And again, you'll do this patient everything from the bedside, such as you get nurses do an ECG, you do all your sepsis bloods, you'll do your VBG, look at the lactate. And at this point, you would have escalated to your senior, or you could have escalated beforehand with this patient as well. At least your SHO. Remember, if you're an F1, you can always just escalate almost anything to your SHO because they were literally there a year ago. And then, should you need, the registrar will tell you again. It's the same thing for all these patients. They get a CT abdo-pelvis, which will guide further management. So a little bit further down the line, the CT shows perihepatic fluid collection. So it's just another case of fluid collection. You've done all your bit as a junior on the wards. You've flagged up the patient. The rest your registrar does. So if they deem it's worthy, you make them kneel by mouth. This patient probably isn't ill enough for HDU input, but they'll tell you who to alert, whether you need to go to the theatre coordinator, whether you need to let the anaesthetist know, and so on. And again, you would have already done your sepsis 6. Just some common points. So I think you've heard this from the other lectures before. Listen to the nurses' concerns because they would have had a lot more experience than you, especially in your very early stages. Sepsis can kill. I don't need to tell final year medical students that. And get your seniors involved early. One thing to mention is, if you ever feel in doubt or the thought of escalating goes through your mind, then just go ahead and do it. Sometimes, especially on ward cover, you'll be wondering whether to put out a met call. You're worried that the whole crash team are going to come and you're going to look silly, but you'll just never really be blamed for putting out a met call, especially if you're just one doctor and you do have an ill patient. It's just a useful tool, basically, to always have. And of course, always prioritize the most sick patients, the most unwell patients according to OBS and your examination first, and then proceed with the rest of your jobs. And that is basically it. So, Cal, I think you might read out some questions if there are.
Yeah, so we've answered most questions as we went along. So, but feel free to put them in the Q&A function now, or I put out Thushanth's email there. One thing I do want to stress is points of feedback here. So, if you scan the barcode or use the link, that will take you to the survey, and you'll get a certificate that's generated automatically. Again, the lecture is recorded and it's going to be online on the NSTS website and on YouTube. So you can always fill out the survey later on afterwards if you want to rewatch the video. So I'll see if there's any questions here. So got a question here.
Yeah.
What would be appropriate imaging to request an F1 who presents with abdo pain?
Appropriate imaging. As an F1, I would say if you're clerking, then do an erect chest X-ray, just looking for pneumoperitoneum. If you're on the wards, I think you don't need to do any imaging till your senior tells you to do it, because more likely than not, they're going to order a CT AP and CT abdo-pelvis. And that's going to be their decision. So just do the basics, just do bloods, and you get told what to do.
Yeah, I would add to that by just saying, like, if you can be a bit proactive, and for example, if someone who's got bog standard cholecystitis, you can think about organising an ultrasound liver, for gallstones. So, it's very much depending on the setting. I don't think as an F1 you'll make an independent decision to CT somebody, because you would have ideally before that stage discussed it with a senior. But yeah, so the basics would be erect chest X-ray. If they're distended, you might get an abdo X-ray, that sort of stuff. So mainly the basics. All right. Okay, I think that's all. The rest were just answered during the lecture. So thanks so much, Thushanth. We'll leave it there.
No worries. Hope you found this useful, guys.